Why aren't nursing home telemedicine visits subject to the same medical necessity standards as every other kind of patient encounter? Hi, I'm Chris Laxton, Executive Director of AMDA, the Society for Post-Acute and Long-Term Care Medicine. In November, the Centers for Medicare and Medicaid Services, CMS, authorized virtual clinical visits known as telemedicine under the 2019 Physician Fee Schedule. Medical care services delivered via telemedicine can include not only examination, but also assessment, management, interprofessional care planning and care coordination, education, and counseling. However, not only are telemedicine visits still limited to rural and underserved areas, but unfortunately, even in those areas, CMS retained the restriction on the number of these telemedicine encounters in the nursing home to only 1 per month for each Medicare beneficiary. This is the case even when there is demonstrable benefit for patients who are frail, elderly, and have multiple chronic and complex medical care needs, along with a lack of easy access to clinical practitioners. This is definitely not the outcome we were looking for, but we will continue to push this issue. A number of studies point to telemedicine programs as contributing to the delivery of high-quality care that reduces unnecessary emergency room visits and hospitalizations. That's why in October, the AMDA board issued a resolution calling for the removal of CMS's arbitrary limits on telemedicine visits in nursing homes and asking that they be based on medical necessity, just like every other kind of patient encounter. The resolution was unanimously adopted by the American Medical Association's House of Delegates at its recent interim meeting, and we look forward to working with the AMA and other stakeholders to effect a change in Medicare policy under the Physician Fee Schedule. We'll also be collaborating with the AMA to ask Congress to broaden the scope of telemedicine models in post-acute and long-term care, and to authorize payment mechanisms for models that are relevant to our patient and resident population. In addition, the AMDA board recently approved a telemedicine position paper that describes some of the key elements involved in deploying telemedicine in PALTC. That paper, which will appear in an upcoming issue of JAMDA, covers 4 broad topics. First, the deployment of telemedicine should be well-grounded in evidence and tailored to meet the unique needs of the PALTC population. Second, PALTC telemedicine should be supported by specific care protocols and standards, as well as quality measures that go beyond current policies and procedures to properly reflect care delivery via this technology. Third, PALTC telemedicine providers should have competency in post-acute and long-term care medicine, in addition to being skilled in the use of telemedicine technology. And fourth, any meaningful expansion of telemedicine in PALTC will require the establishment of appropriate payment mechanisms, starting with the removal of artificial and arbitrary restrictions on its use. If you're interested in learning more, please check out our recent AMDA on the Go podcast on telemedicine, which is available to all at paltc.org/podcast. You can also read the text of our resolution at paltc.org/telemedicine. And thank you.